Today, we're tackling something really central to modern medicine, this paradox we're seeing. We've got AI that can predict disease with, well, almost superhuman accuracy in some cases.
Incredible potential, absolutely.
But at the same time, we face these massive risks when we deploy it, Risks of unfairness, maybe even worsening the very health gaps we're trying to fix.
And the speed of adoption is it's intense.
It really is. I saw a stat last year, something like 38% of physicians said they were using AI. This year, it shot up to 66%.
Wow. 66%, that's a huge leap. Everyone's jumping in, which highlights the urgency.
Exactly.
It's the ultimate high-stakes transition, isn't it? We see the potential AI can speed up clinical research, streamline diagnostics. It really could revolutionize care quality. But this rapid integration, and our sources today really stress this point, it's dangerous without a shared understanding, without consensus. We're seeing more and more evidence that just rolling this stuff out without really strict shared guardrails, well, it significantly bumps up the risk of negative outcomes, often by introducing bias or making existing biases even worse.
And that's the core of it, isn't it? The consensus gap. I mean, at a high level, everyone nods along. Yes, AI should be fair, safe, transparent.
Of course, the principles sound great.
But okay, you're a developer building a new diagnostic tool, or you're on a hospital governance committee deciding whether to buy one.
Yeah.
What does fairness actually mean on a technical spec sheet?
Exactly. That's the missing piece.
Until pretty recently, there was this, well, shocking lack of technical specificity. You couldn't really translate those big ideas into, mandatory auditable rules for institutions.
Precisely. And when the standards are vague, you leave the door wide open for irresponsible deployment. If one hospital defines fairness one way and the tech vendor defines it completely differently,
Press just breaks down.
It collapses. And we saw this crisis really during the pandemic. Remember all those COVID-19 diagnostic models that came out?
Oh yeah, tons of them.
Many claimed really high performance, but then follow-up studies showed a lot of them just failed when used in the real world, and almost all had high or at least unclear risks of bias because they weren't properly validated externally.
So that realization that we needed a single, technically solid rule book, that's what led to a coordinating body.
That's the driving force. We needed someone to create that common standard.
And that body is the Coalition for Health AI, or CHAI.
Correct.
They seem to be the essential group trying to build this necessary technical consensus and create a real roadmap. Their mission, as I understand it, is to be the trusted source for guidelines on responsible AI. AI that serves everyone, not just the places with lots of resources.
And crucially, they're not just writing another set of principles. They're aiming to harmonize what already exists, provide those detailed technical specs for developers, and maybe most importantly, build the actual infrastructure. Like the testing labs, the partnerships, the educational programs needed to actually enforce these standards across the entire healthcare system. It's about making it real.
Okay, so let's dive deep into their work then. Our mission today is to unpack this foundational CHAI blueprint for trustworthy AI implementation. We need to look at the tough technical standards they're demanding, the big partnerships they've built to make these standards stick.
And then we need to zero in on a field where this is incredibly critical: maternal and perinatal health.
Right. Highlighting that tension between, the amazing accuracy we see in pilots and the huge, still unsolved challenge of making it work equitably in the real world. Okay, let's start with CHAI's foundations. The organization seems built to have both technical clout and, institutional muscle. How do they actually come together?
Well, CHAI really grew out of this powerful recognition that, yes, public-private cooperation is vital for AI innovation. But that cooperation needs a common language, a language of assurance. It really crystallized during the pandemic. It just became painfully obvious that all the different players, tech companies, hospitals, federal regulators, were operating with different definitions of safe or effective.
Everyone had their own dictionary.
Pretty much. They needed technically specific, shared definitions that the folks building the AI could actually stick to rigorously.
And looking at who actually authored this blueprint, I mean, it sends a strong message about authority, doesn't it? This isn't just some paper from one university lab.
Oh, far from it. The list of collaborators, it reads like the engine room of U.S. healthcare and tech innovation. You've got steering committee leaders from Duke Health, Google, Johns Hopkins, Mayo Clinic, Microsoft, MITRE E, Stanford Medicine.
Heavy hitters.
Absolutely. But what's just as critical, I think, is the presence of U.S. federal observers. We're talking FDA, NIH, the Office of the National Coordinator, even the White House Office of Science and Technology Policy, OSTP.
So regulators are in the room from the start.
Exactly. That combination, the regulatory observers plus top-tier private innovators, it gives this blueprint immense weight. And it suggests a clear path towards becoming a national standard.
That collaboration feels like the bedrock for trust. Now, CHAI isn't just writing guidelines, right? You mentioned they have 4 pillars of action to actually make things happen. Let's break those down, starting with convene.
Right. Convene is about building that critical mass, that community. CHAI has grown incredibly fast. It's now a network of somewhere between 3,000 and 4,000 diverse organizations.
Wow.
Yeah, and that includes everyone. Huge health systems, insurance payers, small patient advocacy groups, cutting-edge tech startups. They're the ones in the technical working groups, hammering out these best practice frameworks for specific AI uses. The goal is to make sure the final consensus avoids conflicting standards that just confuse people trying to deploy the tech.
Okay, so convene builds the consensus. Then we move to the develop pillar.
Correct. Develop is the operational part. This is where they translate that consensus into practical, ready-to-use resources.
Like what kind of resources?
Things like playbooks, guidance documents, software tools, all designed specifically for the people involved. The developers building the AI, the hospital committee is deciding whether to buy it, the IT team is deploying it. These take the philosophical what of responsible AI and turn it into the practical how. That's the critical step for actually getting this stuff integrated at scale.
Makes sense. The third pillar, certify, sounds like it's about ensuring rigor and, maybe most importantly, independence.
It's the trust mechanism, exactly. Once you have the standards, CHI sets up this ecosystem of certified assurance resource providers. Think of them as independent auditors for AI.
Okay.
These are third-party organizations. The sources mentioned Pacific AI as an example, and they have to get certified by CHI itself. And the absolute key mandate is that they must be conflict of interest free.
Ah, that's crucial.
It is. They provide the rigorous testing, the external validation, the ongoing monitoring that many health systems just don't have the internal expertise or, frankly, the budget to do themselves.
So the company that built the algorithm can't be the only one checking its homework after it's deployed.
Absolutely not. That independence is paramount. It ensures the evaluations of readiness and equity are objective. And these certified assurance labs are especially important for smaller or rural health systems, the ones without big data science teams. It ensures high standards don't just become a luxury for the big academic medical centers.
Right, brings it to everyone. And the fourth pillar is educate.
Yeah, and this one's huge. The pace of AI development is just flat out outpacing the education of the healthcare workforce.
I hear that a lot.
Education tackles that urgent need to upskill everyone, nurses, doctors, administrators, even patients, so they can become critically aware consumers of these really consequential AI tools. I mean, if a clinician doesn't understand an AI's limitations or what its confidence score actually means,
They might just trust it blindly.
exactly, they're much more likely to fall prey to what we call automation bias, just accepting the machine's suggestion without applying their own critical thinking.
Okay, so these 4 pillars, convene, develop, certify, educate, play, they provide the action plan. And this whole thing is anchored by looking at the model's entire life cycle.
Right.
Development, deployment, and then governance or monitoring over time. Why is that life cycle view so fundamental?
It's fundamental because AI systems aren't like traditional software that you just install and forget. They're adaptive, their performance can change and degrade over time. We call this phenomenon model drift.
Model drift.
Drift happens when the underlying data the model sees starts to change. Maybe the hospital's patient population shifts demographically, maybe they change treatment protocols, maybe they even get new lab equipment that reports results slightly differently.
Can you give us a concrete example? How might drift actually cause harm in a clinical setting?
Sure. Imagine an AI model trained, say, between 2020 and 2022 to predict sepsis risk based on EHR data. It worked great on that data. But then the hospital upgrades its electronic health record system. Or maybe they get a new, faster CT scanner that generates images with a slightly different data signature. The AI model, trained on the old data, might start misinterpreting these new inputs.
So its accuracy drops off.
Exactly. It drifts. It might start missing critical sepsis cases it would have caught before, or maybe it starts throwing up way too many false alarms, adding noise. This can happen long after it passed its initial checks.
So the life cycle approach means you have to keep watching it.
Precisely. It mandates continuous monitoring and governance to catch that drift. And then you have a plan. Do you retrain the model? Do you take it offline temporarily? It ensures safety isn't just a one-time check, but an ongoing process.
All right, let's shift from the organizational structure to the actual technical meat of the blueprint. They adapt these NIST AI risk management ideas, map, measure, manage, govern, but really focus them on patient outcomes. Let's dive into the 4 core elements CHAI lays out, starting with usefulness.
Usefulness is really the ultimate goal, isn't it? The algorithm has to provide a specific, measurable benefit, and crucially, it has to be usable in the actual clinical workflow.
So accuracy isn't enough on its own.
Not even close. You could have an algorithm with 99% accuracy, but if it takes a doctor 15 manual steps to input the data, or if the output pops up in some confusing format they can't quickly interpret,
It's useless in practice.
it'll never improve patient care. It has to be seamlessly integrated and easily understood. It has to help, not hinder.
Okay, let's break down the technical bits of usefulness.
Yeah.
You mentioned reliability and reproducibility first.
Right. Reliability is about the model's robustness. Can it handle changes in its environment? This specifically includes resilience against what we call dataset shifts.
We talked about drift earlier. Is this related?
It is related, but shift often refers to applying a model trained in one setting to a different one. For example, you train a model at a big academic hospital with a very specific patient mix. Then you try to deploy that same model in a small rural community hospital. The patient demographics might be totally different. Maybe access to specialists varies.
So the input data looks different.
Exactly. If the model's performance tanks under those new known conditions, it's not reliable. It wasn't robust to that dataset shift.
And reproducibility is slightly different then.
Yes. Reproducibility is about getting consistent results across different places and times, assuming the inputs are the same. If the model works as expected in Hospital A in New York, it should work the same way in Hospital B in Texas, provided both hospitals follow the deployment specs correctly.
Consistency builds trust,
Absolutely. Doctors need to know the tool will behave predictably.
which leads right into testability.
Yeah.
You emphasized earlier this has to be continuous.
Non-negotiable. Testing can't just be something done back in the lab during development. It has to cover the entire life cycle. You need rigorous, ongoing checks verifying performance against all the key standards: robustness, safety, bias mitigation.
And what happens if testing finds a problem later on?
The blueprint demands clear guidance on that. What happens when monitoring detects unintended behavior? Does the system have a fallback, maybe automatically revert to manual processing? Is there a clear audit trail to see what went wrong? This kind of continuous, rigorous testing is absolutely essential for high-stakes tools.
Now, usability also touches on how the clinician actually interacts with the AI. You brought up alert fatigue before.
Yeah, alert fatigue is a huge clinical safety issue. If doctors and nurses are constantly bombarded with notifications, especially for non-urgent things,
They start tuning them out.
they become desensitized, and then they might miss a truly critical alert when it finally does top up. So the blueprint stresses that usability has to consider the context. Is this finding an immediate life-threatening emergency, or is it more of a long-term surveillance finding?
So different types of alerts for different situations.
Exactly. For non-emergency findings, maybe suggest less intrusive notifications. And critically, usability means you have to bring patients and the actual end users, the clinicians, into the design process early. Make sure the AI's output supports their clinical reasoning rather than trying to dictate it.
And the ultimate measure of usefulness, CHAI calls it, the return on health, being beneficial.
That's the bottom line. The benefit of using the AI has to be weighed against the risks and, importantly, compared against the current way of doing things, the status quo workflow.
So it has to be demonstrably better.
Deploying a new AI system should make patient care objectively better or more efficient than the existing manual process, not just, different or fancier. Defining that status quo baseline is tricky, but you have to do it to measure the actual value, the return on health the tool provides. It sets a really high bar. If the AI doesn't offer a meaningful, measurable clinical improvement, why deploy it?
Okay, moving to the second core element, safety. The definition sounds straightforward. Preventing worse outcomes for the patient, provider, or the system than the status quo.
It sounds simple, but the risks here can be really subtle, really insidious. The blueprint flags two critical ones. First, the one we touched on earlier, automation bias.
The tendency to just trust the machine.
Exactly. A provider uncritically accepting an automated suggestion, maybe even overriding their own clinical judgment because the computer said so. Think about a radiologist looking at hundreds, maybe thousands of scans. They rely on an AI to flag potential issues. Now, what if the AI misses a subtle, rare type of cancer? It flags the scan as clear, the radiologist is tired, they see the clear flag, maybe they just agree without that extra close look they might have given otherwise.
Resulting in a dangerous delay in diagnosis.
Precisely. A direct patient harm scenario caused by misplaced trust in the automation.
Okay, that's a clear risk. What about the second major safety risk? You mentioned the danger of using a proxy for a desired outcome. That sounds a bit more complex.
It is, but it's vital to understand. A proxy is basically a measurable variable that you think correlates strongly with the outcome you actually care about, but it isn't the outcome itself.
Can you give an example?
Sure. A classic one in hospitals is using metrics like reducing the length of stay, LOS, or minimizing 30-day readmission rates. Hospitals track these because they often correlate with efficiency and sometimes quality of care, and they affect reimbursement. They're business proxies.
Okay.
Now imagine an AI designed strictly to optimize for the shortest possible LOS. It might prompt doctors to discharge patients earlier. If it pushes for discharge too early, maybe discharging someone who really needs another day of observation or specialized care that's harder to get outside the hospital.
Model hits its target shorter LOS, the patient might actually be worse off.
Exactly. The model achieved its proxy goal, but potentially risked the patient's actual long-term health and well-being. Safety demands, we scrutinize these models really carefully. Does it align with the true clinical goal or just a convenient statistical shortcut that could lead to harm?
That's a really important distinction. Okay, the third pillar is fairness. This is framed as an institutional commitment to health equity by design.
Yes. Fairness, in this context, means ensuring the AI doesn't increase any specific group's risk of a bad outcome compared to other groups or the status quo. It's similar to the idea of non-inferiority trials for new drugs. The new treatment has to be proven no worse than the old one.
So for AI, it means thinking about equity right from the start.
All the way through. From how you select and clean the training data, right through to how you monitor its performance after deployment across different demographic groups, it requires intentional focus.
And the sources detail some specific types of systemic bias we need to watch out for.
Right. Systemic biases are often baked into how healthcare data gets collected and managed in the first place. Measurement bias is a big one.
How does that work?
It happens when the data features used by the model are selected or recorded differently across different patient groups. For instance, say a model relies heavily on doctors' free text notes describing symptoms. If the quality or detail of documentation tends to be lower in busy safety net clinics compared to well-resourced academic centers.
The model gets poorer quality input for those patients.
Exactly. So it will inherently perform worse for the safety net patient cohort, not because the underlying biology is different, but because the data is different.
And maybe the most dangerous bias, the one that seems almost negligent, is missing validation bias.
Oh, this is the definition of irresponsible deployment. It's when a developer creates a model, maybe tests it thoroughly on data from one population, but then fails to test its performance specifically in other crucial subgroups before releasing it for use in those populations.
So launching it untested on certain groups.
Precisely. Imagine an algorithm validated only using data from big city hospitals in the Northeast. Then it gets sold and deployed across rural clinics in the South, or clinics serving predominantly minority populations without any local testing or validation on those specific patients first.
The developers are essentially flying blind with that group's health.
They are knowingly deploying an unvalidated tool on that entire demographic. That is exactly the kind of systemic failure CHAI's framework is designed to prevent through mandatory validation standards.
This leads directly to the concept you mentioned, the algorithmically underserved.
Yes. This term describes patients for whom the AI simply lacks enough reliable data to work well. These might be people whose health records are mostly on paper, not in the EHR. Or they might belong to statistically small population groups. The source mentioned the example of an American Samoan patient.
So the AI just hasn't seen enough similar patients.
Right. If an algorithm flags its own confidence level as low for a specific patient, because its training data lacks sufficient representation of that phenotype or genotype, it's effectively failing that patient. CHAI's mission includes pushing for methods to identify and address these data gaps to ensure fairness.
Okay, that brings us to the fourth and final pillar: accountable and transparent.
Accountability is fundamentally about minimizing harm and ensuring that if something does go wrong, you can figure out why there needs to be auditability. Transparency is the communication aspect needed throughout the model's entire life.
And a key technical requirement for transparency is traceability.
Yes. Traceability means you need to be able to track everything, from how the initial dataset was curated and cleaned, through the model training process, all the way to the final output the clinician sees. This includes knowing exactly how the model performed on different groups and what its confidence level is for any given prediction. You need that clear line of sight.
And the main tool for delivering this transparency seems to be the model card.
The model card is envisioned as the standardized nutrition label for an AI model. It's meant to provide specific, clear information in a consistent format.
What kind of information?
Things like, what is the model's intended use? What are its known limitations? What data sets were used to train and test it? And crucially, what are its performance metrics, broken down by important subgroups like race, ethnicity, age, sex?
And the level of detail varies depending on who's reading it.
That's key. The information needs to be tailored. A data scientist needs the deep technical details, algorithm architecture, statistical methods used. A nurse using the tool at the bedside needs to know its confidence level for this patient and maybe where the model is known to struggle. A patient might need to know simply what conditions this tool is approved to help diagnose or manage. The model card aims to give everyone the right level of specific, auditable detail they need.
That level of standardized detail seems absolutely essential if we're going to have something like a national AI tool registry.
Absolutely critical. The model card is basically the entry ticket for getting into that registry. The registry idea, which we can talk more about, aims to give patients and providers a central place to look up any AI tool being used, check its safety record, review its validation data,
and even see if it's suitable for their specific patient population. Moving towards real precision medicine, but supported by AI that's been properly vetted.
That's the vision. Verified, transparent AI.
Okay, so defining these rigorous standards is step one, huge step. But making them stick across the massive, incredibly diverse U.S. health system, that takes serious institutional leverage. This seems to be where CHAI's operational partnerships really come into play.
They're absolutely crucial. And the partnership announced for June 2025 with the Joint Commission, or TJC, is probably the single most important move for achieving scale.
TJC. They're the big accrediting body, right?
The biggest. TJC evaluates something like 23,000 healthcare organizations and programs across the country. That covers over 80% of all U.S. healthcare organizations.
And getting TJC accreditation is basically essential for hospitals to operate, especially for getting paid by Medicare and Medicaid.
Exactly. It's practically a prerequisite for federal funding. So if TJC adopts standards based on CHAI's blueprint,
the entire industry has to pay attention. It's not really optional anymore.
Precisely. The collaboration aims to co-develop a whole suite of practical resources, governance playbooks, assessment tools, and eventually a new voluntary AI certification program based directly on CHAI's technical standards.
Voluntary, but with teeth, given TJC's role.
That's the dynamic. While the certification might be technically voluntary, for any institution that relies on TJC accreditation, which is most of them adopting these standards, quickly becomes an institutional necessity for managing risk, for dealing with liability insurance, and just for maintaining their basic accreditation status.
I understand they started by releasing some high-level guidance, but the real work now is on these governance playbooks.
Yes. And they're developing those playbooks through workshops, specifically trying to get input from health systems of all shapes and sizes from different regions. The goal is to make sure the recommendations are concrete and actionable. Things like, how do you conduct local validation of an AI tool? What are the requirements for ongoing monitoring? What internal policies do you need around AI use?
And making sure the standards are achievable, even for smaller hospitals without massive resources.
That's a key part of the collaborative approach, trying to avoid creating standards that are so burdensome only the largest institutions can meet them.
Now, this push for equity and making sure standards are accessible can't just stop at the big hospitals. CHAI seems to have realized they needed to specifically focus on the safety net providers. That's where the partnership with the National Association of Community Health Centers, NACHC, comes in, right?
This partnership is absolutely vital for closing that access gap. Community health centers, CHCs, They are the primary care backbone for millions. They serve almost 34 million patients, including 1 in 5 rural Americans.
Wow, huge reach.
Huge reach, but they are often structurally challenged. The sources point out that 60% of all CHCs and a staggering 70% of rural CHCs say that cost is a major barrier preventing them from adopting new technologies like AI.
So if we only develop AI for well-funded systems, we risk making health disparities even worse.
That's the danger. If AI requires expensive infrastructure or specialized staff that CHCs don't have, it bypasses the very populations who might benefit most.
So how is the CHAI and CHC collaboration trying to address these resource limits specifically?
They're leveraging NACHC's existing framework called SEPP, which stands for Science, Education, Practice, and Policy, to really tailor the approach.
Okay, what does that mean in practice?
It means doing joint research projects to validate AI tools specifically within safety net clinical settings, making sure they actually work safely and effectively, even if the data quality or patient mix is different from academic centers. It also means developing educational programs specifically for CHC staff, doctors, nurses, administrators to build AI literacy without needing them to become, data scientists overnight.
Practical education for the front lines.
Exactly. And there's also a really interesting high-impact administrative pilot project they're focusing on.
Oh yeah, what's that?
There's a dedicated Tiger team looking at using AI-powered tools to help streamline Medicaid eligibility and enrollment processes.
That could be huge for CHCs.
Massive. CHC served over 16 million Medicaid patients just last year. Medicaid reimbursement is absolutely fundamental to their financial survival. If AI can safely and efficiently automate parts of that complex eligibility paperwork.
It frees up staff time and helps ensure vulnerable patients don't lose their coverage because of red tape.
That's the goal, improving access and stabilizing the CHCs themselves.
Okay, let's talk about the infrastructure needed to support this whole vision. We mentioned the independent assurance labs. What other practical building blocks are laid out in the blueprint?
Well, the blueprint outlines several critical next steps. For the assurance labs, beyond just being independent, they need to be accessible and affordable for systems of all sizes. They really function as that essential third-party check, confirming readiness and equity before a hospital takes the risk of deploying a new, potentially unproven AI tool.
Then there's the AI tool registry you mentioned earlier, the one analogous to clinicaltrials.gov for drugs.
Yes, this is envisioned as a major transparency initiative. The idea is that this registry would allow anyone, patients, providers, researchers, to look up any AI tool that's been deployed in a healthcare setting.
And see what?
They could access its model card, review the validation data, check its reported performance across different groups, and see if it's deemed suitable for specific patient factors like their phenotype or genotype.
So it takes the AI out of the black box.
It shifts the paradigm.
Yeah.
The AI becomes a verifiable clinical tool, not some mysterious algorithm whose properties are unknown.
And finally, the blueprint talks about standardization and the idea of a sandbox.
Right, we need standardized reporting criteria across the whole industry. If everyone reports performance differently, you can't compare tools or validate results effectively. And the sandbox environment is that crucial local testing platform.
So a safe space for hospitals to try out AI before it touches patients.
Exactly. Health systems need a standardized way to test these models locally, using their own specific patient data, integrating with their own specific workflows before they go live. This local testing is the final critical line of defense against that model drift we talked about and against finding some latent bias that only shows up in that hospital's unique patient population or environment. Catch it in the sandbox before any patient is harmed.
Okay, let's pivot now to maternal health. This is a clinical area globally where the stakes are just incredibly high, where health disparities are often stark, and where the need for trustworthy, equitable AI feels particularly urgent. And it seems highly significant that Lauren Weichert, the founder of Trimester's AI, is actually now a member of CHAI.
It really is significant. It creates this crucial feedback loop, doesn't it? You have developers who are building these complex, cutting-edge AI systems for a high-risk area like maternal health.
So the rule makers understand the technology from the inside.
Exactly. It helps ensure the standards CHAI develops are practical and relevant to the actual technology being built, not just theoretical constructs.
Now, when Weichert talks about her platform, Ester, from Trimester's AI, she makes a really sharp distinction. She says it's not just an application, it's an AI native platform. What's the key difference there architecturally?
It's a fundamental design difference. A typical application might be built to do one specific, often static task, like a simple appointment scheduling app. An AI-native platform, like Ester has described, has artificial intelligence woven into its core DNA from the very beginning.
So AI isn't just bolted on later.
Right. The architecture itself is designed with AI capabilities, scalability, longevity, and continuous learning in mind. It's built to be inherently adaptable, resilient, able to support many different intelligent features and modules over its lifespan, hopefully reducing the kind of tech waste you get from constantly having to rip out and replace static apps. Intelligence and adaptability are core principles, not afterthoughts.
She uses this analogy of building a bridge, something designed to last, to withstand stress over time.
It's a good analogy. The foundational structure is robust, allowing the intelligence layer, the AI models and features to be updated, refined, swapped out over time without breaking the core service. And that's vital because the needs of someone going through pregnancy and postpartum are incredibly complex and they change constantly.
And Esther's described specifically as a multi-agent companion system. That sounds quite sophisticated. How does that actually help, say, a high-risk pregnant patient?
It moves way beyond a simple chatbot or just a single risk score calculator. The idea behind a multi-agent system like Ester is that it's composed of multiple, specialized, autonomous AI agents. These agents cooperate within a shared digital environment, usually coordinated by some kind of orchestrator agent.
Okay, break that down. Specialized agents.
Yeah, think of it like a highly coordinated kitchen staff.
Yeah.
The orchestrator agent is like the head chef. It directs different specialist agents. Maybe there's an agent focused on scheduling appointments, another monitoring for signs of preeclampsia based on wearable data, another providing personalized nutrition advice based on gestational diabetes risk, another identifying social support needs.
So if a patient has multiple overlapping risks, maybe pre-existing high blood pressure, plus developing gestational diabetes, maybe also signs of depression or lack of social support.
Right. The system doesn't just give you 3 separate disconnected alerts or risk scores. The agents are designed to reason together, to collaborate and adapt to that patient's unique, complex, evolving situation.
So it provides more holistic, personalized support.
That's the goal. It synthesizes information from various sources, maybe wearable sensors, maybe data from the EHR, maybe symptoms the patient reports directly to provide support that's contextualized, customized, and hopefully safer and more efficient because it understands the interplay between different factors and can manage complex multi-step care pathways. This kind of decentralized control and more sophisticated reasoning is designed specifically to try and meet the unique, often underserved needs of moms facing those intersecting risks.
And realizing this vision isn't just about the tech, the platform also focuses on empowering the human workforce around the patient.
Absolutely. Recognizing that you need to support the entire birth ecosystem, Trimester's AI apparently plans to offer specialized education specifically for birth workers, people like doulas, lactation consultants, community midwives.
All kind of education.
Focused on AI literacy, what can these tools do, what are their limits? Also on AI governance, how do we use them responsibly? And importantly, how can these birth workers potentially customize or integrate these tools safely and effectively into the specific ways they provide care within their own communities? It directly reinforces that educate pillar from CHAI.
Okay, let's pivot now to the hard science. There's a scoping review mentioned that looked at AI across perinatal care. The technical metrics really show some transformative potential, don't they? What about during pregnancy itself? The image analysis capabilities sound revolutionary.
They really are. We're talking about deep learning models that can segment fetal anatomy on ultrasound images with DICE coefficients greater than 0.90.
DICE coefficient? What does that measure?
It measures spatial overlap. A score of 1.0 would be perfect overlap between the AI's segmentation and a human expert's. So 0.90 means the AI is outlining the fetal structures almost perfectly, often matching or even exceeding the typical variability you see between different human sonographers.
Impressive accuracy. But the real game changer is the speed.
It's the speed. These models can deliver complex fetal biometric measurements, head circumference, femur length, etc., in roughly 13.6 milliseconds per ultrasound frame. Think about that. It takes a human sonographer minutes of careful clicking and measuring. This is near real-time processing.
Wow. And we also have evidence of proven impact, even saving lives, in neonatal care from actual randomized trials.
Yes, this is crucial. The HERO monitor, which uses AI to analyze subtle patterns in premature babies' heart rate variability to detect early signs of sepsis, often before clinical symptoms appear, was tested in a large multi-center randomized controlled trial, RCT. The results were significant. It reduced mortality among very low birth weight infants by about 20%.
20% reduction in mortality. That's huge.
It's a major impact. And beyond that, pilot studies looking at remote monitoring platforms for pregnant women using wearables to track vital signs, activity, etc., have shown links to potentially significant reductions, around 7 to 11%, in overall maternal mortality and the incidence of dangerous conditions like preeclampsia.
Okay, these numbers really hammer home the life-saving potential. Truly remarkable. But the success in these, often controlled pilot studies, immediately brings us right back to those big systemic obstacles that CHI is trying to fix. The unresolved implementation hurdles.
And this is where that tension really bites. You have this stunning technical potential on one hand and the harsh operational reality on the other. Despite all these accuracy wins in research settings, the validation deficit across the field is severe.
How severe?
The scoping review found that only about 16%, one-sixth, of perinatal AI models described in the literature had undergone proper external multi-center validation. That means testing them rigorously in different hospitals on different patient populations than where they were originally developed.
So 84% haven't been properly stress tested.
Essentially, yes. And when researchers try to combine results from different studies using meta-analysis, for example, looking at models that estimate gestational age from ultrasound, they find extremely high heterogeneity between the studies. The I-squared value was around 97.9%.
Okay, what does that I-squared value, 97.9%, mean in plain English for our listener?
It's a devastatingly high number. It basically means that almost all 97.9% of the variation we see in how well those models performed across different studies is due to real differences between the studies themselves, maybe different populations, different ultrasound machines, different methods rather than just random statistical noise.
So the results are all over the place, completely inconsistent between settings.
Almost completely inconsistent. And if you can't reliably reproduce the results when you move the tool from one place to another, you simply cannot trust that tool for widespread clinical use. This is precisely why CHAI is mandating that rigorous external validation before deployment.
And this inconsistency feeds directly into the equity gap, confirming those fears about bias and resource disparity.
The evidence here is really sobering. The review highlights that AI accuracy can drop off sharply, sometimes dramatically, when models developed and tested in well-resourced settings, like North America or Europe, are then applied to populations in low-resource settings.
Can you quantify that drop?
One example cited showed recall that's the model's ability to correctly identify the true high-risk cases dropping significantly, maybe from around 0.95 in the original setting down to 0.80 when applied to certain African cohorts.
So it went from missing 5% of high-risk cases to missing 20%.
Exactly. A 15% increase in missed high-risk cases simply by changing the setting and the population. And compounding this problem is the fact that the vast majority of AI research in this area is concentrated in North America and Europe. Regions like sub-Saharan Africa, which often have the highest burden of maternal mortality, are grossly underrepresented in the data used to train and test these models.
That missing validation bias we talked about earlier, hitting hardest where the need is greatest.
Directly translating to increased risk and potentially widening health disparities for millions of the world's most vulnerable women and babies. It's a critical failure point.
And there's still that final hurdle of just basic technical integration.
Yes, it's the less glamorous but absolutely essential piece. Most AI solutions developed in research labs remain stuck as proof of concept because they lack seamless integration with the hospital's core IT infrastructure, the electronic health records, EHRs, the laboratory information management systems, LIMS, the imaging archives, PCS.
Clinicians aren't going to use tools that make their workflow harder.
Exactly. If using the AI requires manual data entry, logging into a separate system, or disrupts the normal way of working, adoption will fail. This just highlights again why CHAI's broader vision includes things like pushing for better data infrastructure standards and mandating those sandbox environments for smooth local validation and integration testing before you try to roll it out widely.
The Coalition for Health AI, CHAI, is clearly trying to bridge that huge chasm. By building this high-trust infrastructure, independent assurance labs, partnerships with powerful bodies like the Joint Commission to drive standards across most of U.S. healthcare, and by championing specific high-stakes areas like maternal health.
They're definitely moving beyond just philosophical statements. They're aiming for practical, auditable assurance systems. The goal seems to be ensuring that truly powerful innovations, like that multi-agent companion concept for expectant mothers we discussed, are rigorously tested for both safety and equity before they're ever allowed to scale up.
The governance has to catch up to and match the potential of the technology itself.
We absolutely have to move past just being impressed by high accuracy scores in papers and focus relentlessly on the hard work of ensuring safe, fair, and effective deployment in the real world.
Thank you for joining us. We'll see you next time.
Look out for new updates.